Hello, everyone. My name is Fabrice Andre, and it's my pleasure and a big honor to receive the AACR Outstanding Investigator Award for Breast Cancer Research. And the title of the presentation is going to be Moving Toward Precision Medicine in Patients with Breast Cancer. And again, I'm very sorry for not being able to attend, but one member of my family had COVID before I left. So today we are going to discuss three different topics. The first one is whether we can model the cancer biology in each patient thanks to genomics. And this is a starting point of what we call precision medicine. And we will start first with the genomic drivers. So what is the hypothesis here? The hypothesis is that if we can identify the mechanism of cancer progression in each patient and we can block them, then we should improve the progression-free survival and the overall survival. To address this challenge, here is the current flow. We obtain specimen, we perform molecular profiling, then thanks to the molecular profiling and new bioinformatic tool, we identify the target, and then we give the targeted therapy defined by the target. So, what are the possible mechanisms of cancer progression that can be characterized by genomics? And remember, we start from genomics. The first one is what we call the drivers. What are the drivers? They are genomic alteration that are involved in malignant transformation and cancer progression. So the question first to model cancer biology thanks to genomics is whether we can identify these drivers. And here we have a list of 6 questions. The first one is, what are the genomic drivers identified by computational biology in population of patients with metastatic breast cancer? This will provide the rationale to then further identify these drivers at the individual level. And so first question, do we observe in population of patients with metastatic breast cancer some genomic alteration involved in cancer progression? So we perform this analysis together with colleagues in France, where we perform whole exome sequencing of more than 600 metastatic breast cancer. And indeed, we can identify that a large number of patients present recurrent genomic driver alteration, meaning genomic alterations that are driving the cancer progression and that occur in several % of patients. And here we find the usual genomic alteration, TP53, PIK3CA, but we also find some genomic alteration that are enriched in patients with metastatic breast cancer, like, for example, ESR1, KMT2C. We will come back on this later. So this is the first level. The first layer is in patients with metastatic breast cancer, when we perform genomic profiling of the metastasis, indeed, we can identify genomic alteration that drive cancer progression. So then the second question is it beneficial to hit this target? So the second question there is, which impact for the patient of targeting validated genomic drivers? And here I will focus on one illustration, that is the efficacy of alpelisib, an alpha-selective PI3 kinase inhibitor, in patients with and without PIK3CA mutation. And here I want to illustrate what is the targeting of a genomic drivers. And to conclude that indeed the genomic alteration is important and you target a driver, you need to observe 2 things. The first one is that when you give the targeted therapy in patients who present the PIK3CA mutation, meaning the mutated drivers, then you observe a benefit, you delay cancer progression. But to validate a target, to validate a genomic alteration, you need also to show, either in preclinical model, in phase 1, but sometime in phase 3, that your targeted therapy does not have any impact in patients who do not present the mutation. If you do not have a control, it's impossible to validate that it's the genomic alteration itself that matters. Okay? So from this illustration, we can say that indeed, targeting a genomic driver in patients with metastatic breast cancer has an impact on the cancer progression. The implication of this is that there is a need to perform genomic testing in patients with metastatic breast cancer. We will see later whether this genomic testing should be few genes on PCR or next generation sequencing. What are the next questions? Next question is, beside the fact there are some secondary resistance, what are the current limitations of this strategy that is called oncogene de-addiction? And here we are going to illustrate two limitations. First, the issues of patients who present multiple drivers in the same cancer. And I will just take an illustration of this. It's an illustration we see frequently in patients with metastatic breast cancer. They are the patients who present RBB2 amplification and PIK3CA mutation. So this is an illustration of a group of patients who present two different genomic drivers in the same cancer cell. And for this patient, there is a need to move toward combination therapies. For example, here in this clinical trial, patients who present PIK3CA mutation or PS3 kinase alteration benefited from the addition of everolimus to trastuzumab. Okay, so this is the first point. We see sometimes patients with multiple drivers, and for this there is a rationale to move combination therapy. The second issue we are seeing with this strategy of oncogene de-addiction. Oncogene de-addiction is the targeting of an oncogene, a genomic driver. The second issue we are seeing is how to validate the rare genomic segment, and in general, what is the framework to develop drugs, targeted therapy, when the genomic alteration is rare. And this, I just want to highlight one illustration of this situation. It's a report we did with our colleagues from Royal Marsden, the team of Nick Turner, where we observed that in two patients who presented germline P10 mutation, there were outlier sensitivity to AKT inhibitor. But then, of course, this population is very rare, and the question is, how can we validate the genomic alteration, and how can it lead to drug registration in this rare genomic segment? And for this, there are two very important issues that, as a community, we need to promote. The first one is the use of single group practice-changing trial when a genomic alteration is rare and when the targeted therapy is highly effective. The second action we need to promote is the need, when a genomic segment is rare, to develop historical controls. And historical controls are databases that are clinical and genomic database to assess the natural history of orphan molecular segment. As example, the GENI project from AACR is developing very large database of more than 100,000 of patients with genomic annotation. And this will allow us to describe the natural history of patients presenting a rare genomic segment in order to have historical controls to develop drugs in single group practice-changing trials. Okay, so where are we now? We have seen that in patients with metastatic breast cancer, we have some genomic alterations that are drivers and that are recurrent. We have seen that if we target these genomic drivers, that delay cancer progression and better control the cancer. We have seen that there are some issues, patients with multiple drivers, rare genomic segment. Okay, so altogether, this provides a rationale to test multiple genes in each patient. And then the question is it useful to perform multi-gene sequencing, again, to identify the driver of malignant transformation and cancer progression? We did several trials to address this question, starting from the description of the concept, that is the one we just described, is the need to test multiple genes, because in the population of patients with metastatic breast cancer, there are multiple drivers that could matter and explain cancer progression. After describing the concept, we did the first study to describe the feasibility of high-throughput genomics nationwide. That was the SAPHIR-01. We then performed a phase 2 trial that is called Moscato, where we could identify that 30% of patients here had their PFS2 increased as compared to the previous PFS. So the PFS2 was the PFS under a matched targeted therapy. So that suggested that testing multiple genes could be associated with an improved outcome in a subset of patients. Then, based on this observation, we developed a randomized trial testing the clinical utility of multi-gene sequencing. And the conclusion of this trial was that it's useful for patients to get access to multi-gene sequencing if we have the right tool to interpret the genomic alteration. And for this, we used in this trial the SCAT classification for ESMO. What lessons we learned from this clinical development that happened in 10 years? First, it's feasible to perform genomic profiling using high throughput technologies, other arrays of NGS. Next generation sequencing facilitate logistics because you have all the gene in one assay and allocate patients to genomic-driven trials. This approach is effective only in patients presenting a genomic alteration previously validated in therapeutic trials. This is SCAT1, 2. This is the SAPHIR-02 trial. Point number 4. Today, we do not have the validated tools to interpret the genomic variant that have not been validated in therapeutic trial. What it means that if the genomic reports include a mutation that has not been validated as a companion diagnostic or that has not been associated with objective response in phase 1, it is not useful in terms of public health to use this information for the patient treatment. Last point, why are we so bad at identifying drivers outside the recurrence validated one? And this is the message of this first part. There are multiple number of recurrent drivers in large number of patients. But when we use multi-gene sequencing, it's only the subset of patients who present a validated genomic alteration that benefit from the drug. So it means that in a large number of patients, we are not capable to identify what are the driver molecular alterations. And we will discuss this in the second part. So what are the take-home message? First, there are genomic drivers in patients with metastatic breast cancer. Some of these drivers are still underexplored. Targeting a drivers leads to anti-tumoral effect in patients with metastatic breast cancer, meaning there is a need for genomic testing in this population of patients. The strategy of oncogene de-addiction is facing several challenges: co-mutation, drug development in rare genomic alteration, occurrence of secondary resistance, how to optimize the characterization of drivers. So then we are going to move to the second part of this presentation. And now we have seen, I would say the first layer is the description of recurrent genomic alteration that are drivers. Now the next questions, the two next questions are how to avoid secondary resistance and how to improve the accuracy of driver identification. That are the two big challenges we are facing to model cancer biology and improve patient outcome. So, how to decrease the likelihood of secondary resistance? And here I will just discuss 2 points. The first one is the identification in each patient of the mechanism of immune suppression. Again, is the first part of the presentation. It's about genomics. So here the question is, can we characterize the mechanism of immune suppression thanks to genomics? Using the immunotherapy arm of the SAPHIR-02 trial, we could identify that CD274 amplifications, that is a gene coding for PD-L1, you can see it here, was associated with outlier sensitivity to anti-PD-L1 antibody, here durvalumab. So what it means here, it means that some cancer present amplification of the gene coding for PD-L1, and this amplification leads to overexpression of PD-L1. That is the mechanism of immune suppression in this patient. And so this is an illustration that thanks to genomics at the cancer cell level, you can identify a mechanism of immune suppression for each patient, and you can target it by anti-PD-L1 antibody. And that leads potentially to decreasing the likelihood of resistance to targeted therapy. The second topic, to delay secondary resistance or to avoid secondary resistance, is the genome evolution. Can we model in each patient the mechanism of genome evolution? And for this, there are two questions. The first is, can we use genomics to characterize the resistant clone? And I will not discuss this point. The second question is, can we characterize the mechanism of genome evolution in terms of mutational process? In other words, can we use genomics to understand in each patient what are the mutational process that create the evolution of cancer? And for this, I would just like to highlight one mutational process, that is ApoBec. ApoBec is a cytidine deaminase that transforms a C into T, so it's a mutator. When it's active, it creates mutation. And the question here is whether this cytidine deaminase is involved in the genome evolution of patients with metastatic breast cancer, in the genome evolution of the cancer. What we have observed when we did the whole exome sequencing of metastatic breast cancer is that indeed we can observe in metastatic breast cancer an enrichment of mutations related to ApoBec, leading to the hypothesis that this ApoBec could be involved in the genome evolution and in the escape resistance to targeted therapy. This is a hypothesis. Now there are some basic science labs, like the one of Ruben Harris in Minneapolis, working on this hypothesis to validate it and to develop and design drugs that could target this mutational process, because we need to understand that if we can identify in each patient the mutational process that will lead to acquisition of mutation resistance, if we can block this mutational process, it should delay the occurrence of drug resistance. Okay. Where are we now? Now we have seen that thanks to genomics, we can identify drivers in some patients, some mechanism of immune suppression. We can, in the future, identify mechanism of genome evolution. But what we have seen and what we have told is that genomics does not allow to model cancer biology in most of the patients. So it means that we need other technologies to model cancer biology in order to have a comprehensive analysis of each cancer. For this, we need two things. First, new technologies for profiling. Second, new methods to analyze data. And this is a project we are developing now, PRISM project, that is modeling cancer biology in each patient thanks to a comprehensive molecular profiling that goes beyond genomics. Right? Genomics was the first layer. Here we are talking about additional technologies. What are these technologies? Phosphoprotein, ex-vivo device, epigenetics, and spatial proteomics and genomics to predict sensitivity to biological therapy. I will not discuss this in this presentation. Phosphoprotein. Why do we need to assess protein activation? Because it's a good complement to genomics. When you have a mutation, it's always useful to see if this mutation leads to activation of the pathway. Example, we reported in the Bolero 3 trial that high level of phosphorylation S6 was associated with high sensitivity to mTOR inhibition. This is an illustration of the use of phosphoprotein to identify patients who get benefit from a targeted therapy. So it's a good complement, a good technology to identify and characterize drivers. The second emerging technologies are the use of ex-vivo device for disease modeling. This is the field of organoid, microfluidics, and spheroid. I will not go into detail, but just to say that now we are putting a lot of investment to develop organoid to model cancer biology in each patient. Technology number 3, we are developing to have a comprehensive molecular profiling is the profiling of the epigenetic landscape. And as you can see here, this is the overall unsupervised clustering of the ataxic in 200 samples of breast cancer. What I mean here is that we can now perform ataxic to assess the chromatin access in each patient, and we will use it in the next few years to better understand the deregulation of gene expression. In addition to modern technology to have a comprehensive profiling, there is a need to develop new method to analyze the data. And here I will just spend 1 minute on an interesting data we had. What we did, we asked a machine, a deep learning model, to learn in a pathology slide, in an H&E slide. Can the machine learn what are the features associated with poor outcome? Interestingly, the machine identify features associated with good outcome and poor outcome. But what is interesting is that without saying anything to the machine, just asking the machine to identify the feature associated with poor outcome, interestingly, the machine identify poor differentiation and proliferation. So this is extremely important. It's a proof of concept that a machine, a deep learning model, can learn based on H&E slide what are the features that are important for the patient outcome. So this is for us an important proof of concept that new mathematical tools like artificial intelligence could allow in a near future the oncologist, the researcher to better understand in each patient how to model cancer biology. So now move to the third part, but I will go very quickly in 1 minute. What we have seen is that genomics can be helpful as a first layer to model cancer biology. We need new technologies to have comprehensive profiling, and we need new mathematical tools to interpret and to analyze the data. Now, what I want just to say in 1 minute is that a lot of effort in precision medicine focus on the modeling of cancer biology, but one of the key challenges is to broaden the scope of precision medicine. And here, we first need to have tools for the early identification of patients with hard to treat cancer in order to propose investigational compound as soon as possible in the disease course. And second, we need tools to predict toxicities. And for this, we develop a prospective trials with 12,000 patients named CANTO, with all the blood, plasma, serum, all the questionnaire in order to predict toxicities and to personalize therapy to avoid toxicities. And just want to say that samples and data are available upon request. Perspective. What are the perspectives? What is the question? Perspective in the next 10 years will be to construct a drug for each patient. Why? Because modeling of cancer or patient biology is going to generate some comprehensive molecular profiling where we will not have the drugs or where the drugs needs to be constructed. And the question is really, can we in the future construct a drug for each of the patients? Actually, we are already doing that with 3D printing in a trial that Ines Vaz-Ruiz is leading, and with fecal transplantation, but we need to move further in this concept. And I take the opportunity to thank all my colleagues, founders, and friends. Thanks again for this important award.